Dear colleagues and friends, ladies and gentlemen, my name is Nicolas van Mieghem from the Erasmus University Medical Center in Rotterdam, and on behalf of all my fellow course directors and faculty, it is my true pleasure to welcome you to the 2022 edition of Transcatheter Interventions Online. This year is already the third edition of TIO, and we will follow our magic recipe. TIO brings back the same stellar faculty with the top physicians you know and who matter in both clinical practice and science. It is a mixture of mini presentations and panel discussions and plenty of live cases that should help shape your practice of now, but also of tomorrow. As always, the first day will cover the structural heart space. The second day will focus on complex coronary interventions, namely calcific coronary artery disease and CTOs. And the third day, we host the great Valentin Fuster for a keynote lecture and have exciting debates and discussions on topics that matter in today's world of interventional cardiology. Don't forget the symposia and breakout sessions supported by our sponsors for more high-quality content. And let's just some general facts related to TIO. We have over 5,200 registrations, and the registered people, they come from 165 countries. By the way, there are 195 countries in the world, so we're quite well represented. We will have 11 live cases, and for the first time there will also be a live case in one of the breakout sessions. And then there are multiple breakout sessions every day between 5 and 6, including the TIO course directors, the presenters, the panelists and the case operators. We have over 40 faculty members, so it's quite a big meeting this time. And so without further ado, I think we are all ready. I hope you are ready. TIO 2022, let's go. Get on. The first day of TIO, as mentioned, will focus on structural heart interventions, and the first session is on next level structural heart interventions. I'm delighted to be joined here in this session by true experts in the field. Azim Lateeb from Montefiore Medical Center, New York. Also Kendra Gray from Emory University in the United States. There is David Hildesmith from Brighton. And there's Professor Lars Sundergaard from Rigshospitalet in Copenhagen. So I think what you're also used to expect from us, we start sessions with poll questions. And in the first poll question, we like to know what your expectations are related to transcatheter mitral valve replacement. Do you think it will become an alternative to surgery in patients at low operative surgical risk? Yes or no? And for our audience, please submit your answer to the poll tab on the left-hand side panel, and we will get back to you to see the answers towards the end of the session. So with that, I think it's time to go and start with the first presentation by my good friend in New York, Azim Lateeb, and he will discuss an update on transcatheter mitral valve replacement technology. Azim, the floor is yours.
Thank you, Nicholas. It's always a great pleasure to be part of TIO. It's such an innovative way to make sure our colleagues get educated on really the latest technologies and advances in our field. And one of those advances is transcatheter mitral valve replacement, and I'd like to give you a short update on it. These are my conflicts of interest. So why talk about replacement? Well, replacement will give us, I think, a more durable reduction in mitral regurgitation. We know that residual MR affects survival, and with transcatheter edge-to-edge repair, we do, depending on the study you look at, see a lot of residual MR. We also know that there are a number of cases where we just can't do TEER, either because the valve's too small, there are multiple jets, there's calcium on the leaflets, on the annulus, and we need devices that will allow us to treat all of our patients. There are a lot of exclusions. We don't know really what the exclusions were for COAPT, but we think that at least 60% of cases were excluded. And we need more predictable and reproducible outcomes. Here's just a summary of some of the data from studies looking at mitral devices. And what's really incredible with these replacement technologies is the fact that you really abolish MR. I mean, look at this, 0% of patients had MR that was greater than 2+ at 1 year. And these were with current transapical technologies. We don't see that kind of result with repair. And I think that's why we need replacement. So what are the devices that are actually being implanted currently around the world? Here's a summary of them. I'm going to very quickly go through them, but concentrating initially on the ones where we have more clinical data and that are in randomized clinical trials. So let's start with the device that has the most clinical data, which is the Tiara device. But just to highlight before I do that, that even though we're talking about replacement, this is still a technology that is in very early stages. We're getting close to only 1,000 implants in patients with all these technologies put together. So we still got a long road to learn about how to use these technologies in the future. I apologize, but okay. So Tendyne is the one that has the most clinical experience. It's a transapical device with a apical tether and epicardial pad. It's self-expanding nitinol. It has multiple sizes, and really the device that has been most implanted. It's also now received CE mark approval and is commercially available in Europe. It's retrievable and repositionable, and so even if you do have issues as regards to the left ventricular outflow tract, you can remove the device. And when you look at the 2-year follow-up, the mortality rate's high, 39%, but because of how sick some of these patients are, but this device works. There's residual MR in no patients, MR less than 1 in 100 patients, improvements in quality of life and NYHA. And so this device is in the United States being studied in the SUMMIT randomized trial, and you see the design of the study here. The main part is that if the heart team believes that this patient has anatomy suitable for repair and for mitral clip, then the patient can be randomized to either Tendyne or mitral clip. So mitral clip's the control. There's also a single arm for MAC, and for patients who are not randomized and can be treated with MAC. And I think this study will be very important to show that replacement in the field of mitral has an important part to play. Then the Intrepid valve, slightly different valve. You've seen this before, double stent, self-expanding nitinol design with bovine leaflets. The inner valve is 27 millimeters, but there are 2 actual valve sizes, which we'll see in a moment. It can be implanted transapical and transfemoral. And here again, we are doing in the United States a study to evaluate Intrepid called the Apollo study. You see the design here. Again, patients who are eligible for surgery can be randomized to either TMVR or surgery, but really the most important part of the study is the single arm cohort for ineligible patients, which will allow us to really understand how this technology works in patients who are not surgical candidates. the study started as a truly transapical study, but the technology has changed. There is now a transfemoral, transseptal version, which you see here, and early feasibility studies underway with really promising clinical outcomes, which you see here in the first patients that were treated. These are the first 14 patients treated transfemorally with Intrepid. And again, look at, non-trace MR at 30 days, really no patients with moderate MR or more, even with transfemoral implantation of this valve. So those are the two that are in randomized clinical controlled trials right now in the United States, but there are some others that we need to know about because they have been implanted a lot. The Neovasc, also large clinical experience, close to 50 implants. There's the Tiara-1 and Tiara-2 study. Currently, this has been only a transapical device, but the company is working on a transfemoral device as well. And here you see the data on the first 79 patients with a 12.7% 30-day mortality. And again, minimal residual MR. And I think this is important. This device anchors in a different way. You saw we had an apical anchor, then we had Intrepid that anchors on the annulus. This actually has these tabs that anchor anteriorly and posteriorly, which we can talk about in the discussion, has advantages and disadvantages. Then there's the Edwards M3, a very different way of anchoring a valve. This is one of now a number of technologies that's using a docking system at the mitral valve to then implant a valve into it. So you first implant a dock into the native mitral valve and then implant your valve into this. This is the smallest profile system that there is. Very promising clinical data in early feasibility and compassionate use. And there's a large single arm study called Encircle that has started now in the United States to further evaluate this device. Edwards has two technologies for the mitral. We saw the M3. There's also the Edwards Evoke system. This is what the valve looks like that was initially implanted in both mitral and tricuspid. It's a 28 French transfemoral system in two sizes, 44 and 48. And EFS has been underway with really encouraging clinical outcomes. As you can see, low mortality rates, and again, very good MR reduction rates in a highly selected population. That device has changed, and there is an updated version that looks a little different. You can see here called EOS, which is a version that will be now implanted in the mitral. The anchors are slightly different. It's covered in a different way, and it's just really a modification of the device that was initially used and that is still being used in the tricuspid. Again, available in two sizes, 44 and 48. Okay. So those are the ones with the most clinical experience. And as we go down, we go to those with a little less clinical experience. High Life Medical has probably now around about 30 implants around the world. Again, this is a device that uses a docking system. You first implant an anchor around the annulus and then implant your valve into it. Also, very promising technology. And then we see some of the newer technologies, some of them really out of the box, like the 4C Medical Alta valve. This is the circular spherical structure that's implanted in the left atrium with a valve that's supraannular. So imagine, for example, a patient who's had 2 or 3 mitral clips where those have failed, and you wanted to treat that patient. This would be an ideal valve to put in the atrium above it. It has a large footprint, but you could see that you really don't have to worry about the LVOT when you're implanting a valve like this. So this is being currently evaluated in early feasibility. And then we have a couple of other valves that are also being implanted. There's CardioValve that's now been bought by Venus MedTech, which is a transfemoral 28 French version. Compassionate use cases are currently being done, but there is an early feasibility that will start up again in the United States. And then the Sophia valve from Abbott, which is their transfemoral valve. A number of compassionate use cases have been done. Very interesting technology, protrudes very little into the left ventricular outflow tract. Currently only one size, 36 millimeters. But again, I think we're going to see more implants with this in the upcoming year as there is an early feasibility. So, we've seen a lot of growth in this field. with 3 technologies bought in 2015 for over $1 billion, but there's still, I think, a number of limitations we can discuss. A lot of them are still transapical. When it's transeptal, there's a very large French size. We still have some paravalvular leaks. We need to think about thrombosis, and we certainly can't treat all populations. There's still a very high failure rate. And here's a number of studies that have been publishing that showed that probably only 1 in 3 to 1 in 4 patients who are screened for these studies are actually accepted into it. So even though they are technology that's interesting, there's still a very high screening failure rate. So I'm going to conclude, hopefully I can get to my final slide. I think what's the future? If we think about the future of this field, I think we all believe transeptal delivery of these devices will be the future for majority of these devices. Our issue is that there's a lot of patients who are excluded anatomically. The main reason is either due to the size of their annulus or due to LV outflow tract obstruction. So we're still learning a lot about patient selection. We're definitely going to need ways of modifying the LVOT. Even though the devices will get better and protrude less than the LVOT, we'll still need techniques to modify the LVOT, and we'll need better imaging techniques in order to be able to do these procedures successfully. Thank you so much, Nicholas, and maybe we can open this to discussion.
Thank you very much, Azim. That was the ultimate TMVR parade. You clearly demonstrated that several of those technologies have transapical or a transapical and a transfemoral iteration. So maybe the first question for Kendra. Obviously, we all know that Kendra is a surgeon. What do you expect from transapical TMVR? Is that a technique that is gonna last, or is it a transition towards transfemoral for all TMVR?
Well, I think as you go forward, you're going to have to get a transeptal approach, so a transfemoral, as you're calling it. Just like in TAVR, where the original devices were so large that required a transapical, you'll probably still need some platform that's transapical, but I don't think this is going to be the mainstream approach for TMVR as we go forward. It's not well tolerated, especially in high-risk patients, and right now, that's the patient population we're targeting. And that mini thoracotomy, the transapical incision, we learned it in TAVR, and we're going to have the same type of experience in TMVR.
David, what do you think is the biggest concern for TMVR at this point? Is it the anchoring, or is it the neo-LVOT that gets obstructed? What do you think?
So I think there are two big things going on at the moment. One is the LVOT issue is a major issue. The mitral valve is incredibly clever the way it opens and then shuts and allows the blood to go out of the aorta. So anything that leaves the mitral valve leaflets open is going to be a problem. And we're going to have to work out ways of dealing with that. Now, some of the technologies that encircle the subannular groove and hold the valve tight should have a much lower incidence of LVOT obstruction, but that's going to be a massive Achilles heel ongoing for these technologies. The second one for me is that everyone's playing cat and mouse. Nobody wants to make a false step, so everyone's been incredibly cautious recruiting patients to these studies because there are too many players in the field, and it feels like if one technology makes a false step, they're going to be excluded and leave only 8 runners instead of 9. And so everyone's going incredibly slowly. As Azim said in his great talk, this has been going on for years now, and yet we're still only got, 1,000 plants globally compared to however many millions and millions of TAVI.
So, but still, TMVR is going to come eventually. So, Lars, in your opinion, does that mean that we also have to be aware when we do transcatheter mitral valve repair that we need to keep that option of TMVR open?
Yeah, that's of course the limitation, because the far dominant transcatheter therapy for mitral regurgitation today is TIO, it's edge-to-edge repair. And it is today that is going to close the door for valve replacement subsequently. I know that the companies are working on a system which can potentially remove that clip from the mitral valve and thereby make it feasible to do a replacement later on. But for the time being, you have to be very careful about selecting your patients because, as I said, if you're going for TIA, it will exclude the patient from replacement later on. So it's an important decision to make up front.
Azim, you have a lot of experience with these devices. You have implanted several of them. What is the rate of basilica that you need? Because there is a concern, as David already alluded to the native leaflets that you're pushing away towards the LVOT. Do you often do a basilica in those kind of things?
I think you mean lampoon, basilica.
Yes.
So for the audience, what Nicholas is talking is LV outflow tract modification. So in some of these cases, we will try and take them on if we can modify the left ventricular outflow tract, which means either you modify the leaflet and cut the leaflet in half via lampoon technique, or you modify the septum, the ventricular septum that's protruding a lot, or you do both. You can modify the septum either by alcohol septal ablation, by radio frequency, or by a new technique developed by Kendra's colleagues called Sesame, where you cut it open. But those techniques, Nicholas, right now we're not performing many of those because most of these patients are being treated in the context of clinical studies. So like David said, the companies are being overly cautious. They would rather say no to the case than let us do a lampoon with the case. Some of the companies are now realizing that lampoon is becoming very reproducible, so you can do it. But the more you cut the leaflet, the more hemodynamic instability you have, and so you need to be able to implant the valve then quickly as well. I think the company that's been the most aggressive at looking at this has been, Abbott with Tendyne. They've done now a number of cases where there's been an edge-to-edge failure or mitral clip failure, and they've now cut the leaflet and pushed the clips to the side and then quickly implanted the valve. But that's what I put in the future. I think for this technology to become anywhere close to what TAVR is, we're going to need better devices that don't obstruct the LVOT, but I'm not sure that will be enough. We're going to need ways to also do what Kendra does with open surgery, which is cut away the anterior mitral valve leaflet so it doesn't obstruct.
Yeah. Well, thank you very much for this fascinating discussion. I think what is clear is we are still in a very dynamic field and there is still a lot to come. But I think you made a very smooth transition to the next presentation because we want to know and learn and maybe predict how a device will interact with the host. And there is some technology already available, and Lars and his group in Copenhagen is an expert with those device host interactions paradigms. So the next presentation will be provided by Professor Lars Søndergaard from Copenhagen to talk the potential to predict device host interactions.
Yeah, as Nicholas is saying that we want to have proper pre-procedural planning to have the best outcome for these interventions. And I'm going to just touch on 3 different kinds of intervention: left atrial appendage closure, TAVI procedures, and as we just discussed, transcatheter mitral valve replacement. So we know if you start with the left atrial appendage closure that most of the sites, or many sites today, is using echocardiography, transesophageal echocardiography, or maybe even angiography for planning the procedure. So they use it to measure what is the size of the orifice, the landing zone, and the depth of this structure. And then they're going to decide what size device that they're going to use and where is the device going to be implanted. But we know, if you see here on the left-hand side, if you use transesophageal echo, even in multiple angulation, that if you want to measure diameter, there is a certain uncertainty about these measurements. And if you look at TIO today, no one would start a TIO procedure without having a pre-procedural CT scan. And that's the same movement you now see also in left atrial appendage closure, that people are using CT scan to have better understanding on the anatomy and the sizing. So that's just as TIO is going to give you both what is the perimeter-derived diameter, what's the max diameter, what's the depth of this structure, and thereby have a better pre-procedural planning. And actually, CT scan is a very nice tool to plan this procedure. You will see where to puncture the septum, where to put your C-arm during device implantation, which device you're going to use, what size device, and how deep it should be implanted. So here, this is just one example here. On a CT scan, you can measure again what is the maximum diameter of the ostium, and if you look at so you have a proper size. If it's a disc device you're going to use, you can look at the landing zone, have the max diameter or the perimeter-derived diameter in order to have the optimal device size for this patient. And there are now also more sophisticated tools out there. This is from Materialized as a software company, where you can see these three curves. You have the center line, it's a blue one. You have the yellow one, this is the minimum diameter in each position, and the red one is the maximum diameter. So you can choose where actually to implant your valve and see what is the size of the left atrial appendage at that position. And again, that's going to give you a better understanding which device is going to fit the patient best. Also, the purpose of closing these left atrial appendage is to have complete seal, so there's no risk of thrombosis formation and thereby embolization. And we know that it's possible to, from very cheap and very easy, to have these 3D models printed out after these CT scans. And if you want to see how a device is going to seal, you can do it here, as my colleague Ole Bakkert has showed years back. Use those small aluminum beeps here, put them into it about 2 millimeter size. And when you've done that, you implant your device in that 3D model, just to see whether it's actually going to seal up for these beeps. So if you have a leak, a per-device leak, which is more than 2 millimeter, these beeps are going to come out. So after implant the device, you can do this shake test and see whether the beeps are going to stay in the left atrial appendage or if they're actually going to come out, indicating a leak. And you can also, afterwards, when you have done that shaking, taking this 3D model under the fluoroscopy and see whether it's actually going to seal off ideally. This is maybe a first start, a very simple way to do it. But now there are more sophisticated tools, and this is from FEOPS, the heart guide here. So using computer modeling, you can actually try to test different type device. It could be an amulet, as shown here. It could be a Watchman Flex, different size devices, and also different implantation. And if you look here at an amulet device, 18 millimeter, in a proximal position, you can see that it's only going to give you 9% compression, whereas you go to a deeper position, it's going to give you a 19% compression. So this will allow you to, again, upfront, to choose which size type device you're going to use, what size it should be, and where should it implant it in order to have the the optimal outcome after device closure of these left atrial appendage. So moving from left atrial appendage closure to TIO procedures, it's also possible here using these softwares to have a better understanding how well is a device going to fit into the patient. So it's going to help you. Is one device better than another device? Is one size device better than another size? And how high or how deep should it implant it? And you can see here, this is 4 different cases. You see in the top, the calcium burden. You see on the middle row, this is what was discovered on post-procedural CT scan. And in the bottom, what was predicted from this FEOPS software. And you can see it's very similar from the prediction from the computer modeling from what you actually see in real life using a CT scan after the procedure. And it's also been used to demonstrate 2 of the important risk factors of TAVI. First of all, what is the risk of conductance abnormality, a new permanent pacemaker? And from the CT scan, of course, you can identify the membranous septum, and you know just below the membranous septum, you're going to have the conduction system. And if the device is too deep or applying too much pressure on that, you're going to have a high risk of conductance abnormality. So again, these computer modeling can tell you what is the risk for a specific device in a specific position to have a need for permanent pacemaker after device implantation. The second issue after TIO procedure is the risk of paravalvular leak. And once again, you can see here how well adapted is the device to the wall, how well is it going to seal off, and thereby how high is the risk to have paravalvular leak afterwards. So again, using these devices, you have these two very important information afterwards. And also if you're going to move to a patient with bicuspid aortic valve, with or without a calcified valve, it's going to also tell you how well is the device going to adapt it, and how will this potentially impact internal leaflet position of your devices here. So again, also for TAVI, it's going to provide very important information about what is the risk of conductance abnormality, what is the risk of paravalvular leak, and also what is the leaflet function and potential durability going to be after a TAVI procedure. So moving to the last topic here, transcatheter mitral valve replacement. You just heard Asim's excellent talk here. You can also, with using these software here, predict how is this device going to sit in the mitral annulus after deployment. It's of course going to depend on what is the size and configuration of the mitral annulus, what is the calcium burden and distribution, and what this device are you going to use here. And as we just discussed, one of the most important risks for these procedures is that you're going to create a new left ventricular alpha tract obstruction. So again here, it can, as you see here, both predicting from the computer modeling and from the post-procedure CT scan, have a very accurate prediction of what is the risk of new LVOT obstruction. So just to summarize, what is the prediction of device-host interaction? You can use it to select the optimal device type, device size, and implantation position. For left atrial appendage occlusion, it's going to reduce the risk of peer-device leak and device-related thrombosis. For TAVI, it can be used to reduce the risk of conductance abnormality and paravalvular leak. And for transcatheter mitral valve replacement, reduce the risk of paravalvular leak and new LVOT obstruction. Thank you.
Thank you very much, Lars. This was an excellent presentation and overview of these concepts of device-host interactions. And you know, make no mistake, this is advanced engineering what is behind all this, because you are taking into consideration characteristics of both the device that you're implanting, but also the receiving tissue. Is this an exotic way of planning, Lars, or are you doing this often in your clinical practice?
In our institution, we do it routinely before a left atrial appendage occlusion. Everyone will have a CT scan. We're doing this simulation modeling. I wouldn't say we use this sphere software for all patients, but we use it in selected patients. And actually, my colleague Ole de Backer has done a randomized trial using this sphere software to predict, try to decide which kind of device and which kind of a position should be used for left atrial appendage closure, with the primary endpoint of peri-device leak and device-related thrombosis. So it's going to give additional information whether it's going to improve the outcome in daily clinical practice.
Mm-hmm. And do you need to outsource this, or is this in-house technology?
Most of it you can do in-house with available software you got. Tremensio is a software most of us is using for planning these structural heart disease interventions. The more advanced as FIOPS and Materialize, you still have to contact the company to have it done on patient level. But I'm sure it's soon coming to be a commercial available software so you can do it yourself in your own institution.
Okay. So Kendra, how do you foresee that the field will move forward? Are we going to use this kind of technology for patient or anatomy-specific device selection?
I think it's really important to be able to optimize whatever technology we're going to use. Now we have to keep in mind that we are limited by some of the constraints of the technology. So it's great to be able to simulate a valve being in perfect position, but are we able to actually achieve that when we go to the lab? And that's one of the variables that we can't control for. But are we going to be seeing more and more 3D printing? I do believe so, especially as we get into the heart failure devices. Some of the ventricular remodeling devices, we will do a 3D model of an actual implant for every patient so that we can really understand the anatomy. For TAVR, I think it's a unique way to look at it, but certainly all of the computer modeling, whether it's 3Mincio or whatever your local team uses, that is essential in sizing the valve and planning which is the correct valve for this patient's anatomy.
Start. Okay. David, what is your take on this? Are you using this FEOPS technology?
We have used it a little bit in a research setting, but I'm not sure about this. CT is absolutely crucial for TAVI. If you don't do a CT and you put in a balloon expandable valve, you will have a number of cases with annular rupture, and these are fatal. So it's absolutely crucial in that. For left atrial appendage occlusion, I'm not entirely sure. I kind of think probably what we need is softer, more compressible, more expandable devices so that some of these nuances aren't required. And of course, the effects of getting the wrong size are not usually terrible because you just have a missize and you choose another product. So, and generally, personally, I'm always looking to simplify procedures rather than add layers of complexity for the patient. The patient would have to come back another day, travel, have another 60 mils of contrast, have the CT done. So I don't know. I mean, it's obviously enables good planning, but how often it will materially influence the outcome of the procedure for left atrial appendage occlusion, I'm not sure. But that's because I'm by nature a minimalist.
But do you think it might help you with choosing the kind of technology that you would want to use, like an Amulet or a Watchman or another device, or is this more an experience thing?
No, I think it definitely could help you choose the device. But for example, you look at the Amulet and its applicability, 99% of anatomies an Amulet is going to fit. So do you need a CT scan to help find the 1% way it might not? I don't know. And what I foresee is iteration in the designs of the appendage occluders such that you almost have a single device, a bit like a sort of candy floss or marshmallow which fills the left atrial appendage, and you don't really need any of these planning things, because in the end what we want to do is any time we're in the left atrium go, we need to close off the appendage whilst we're here. That's the goal in a sense of left atrial appendage occlusion therapies, rather than having them as too complicated a procedure.
Got it. Azim, in your opinion, we've seen 3 examples of using the FEOPS technology. We've seen it in the context of TMVR, LAA occlusion, and TAVI. What do you think, where would it fare the most? Where would it be most effective? Is it in the TMVR, in the LAA? What do you think? Yeah. Azim, sorry, we have a sound issue. We cannot understand what you're saying. Yes, we cannot hear what you're saying, so let's try to solve the sound at Azim's end. But maybe the same question for Lars. What is your opinion on this?
Yeah, again, I think it will fit in all 3 therapies. And today, everyone who's going for TMVR today have a CT scan and they have a computer modeling before accepting their patients. But just one comment to what Dave is saying about left atrial appendage closure and other structural heart intervention. Just remember, persons like David are expert in these, and they will make it work in most patients. But if you want to broaden these therapies out to more sites with less experience or newer operators, I think if you have a proper pre-procedural planning, the chance to have a successful procedure is going to increase. It may not make a big difference in highly experts, but for ordinary operators, it may change the outcome.
How is the sound at Azim's end? Is it better, Azim? Do you hear us?
but can you hear me?
Yeah, we can. We can.
Okay, great. Now, I was just saying, you know, for me, I can see this being used in many different technologies and procedures we do. I mean, I think we all talk about TAVR being so mature, but if you had a way of predicting in your low-risk patient which was going to be the best first valve to put in so that you could plan for TAVR and TAVR, I think that would be a great use. But also, if you think of procedures like edge-to-edge repair, I still get frustrated at times because it's not always reproducible, right? Sometimes you think you're going to have one clip, you end up with two. Sometimes you think you need a short clip, you end up with an NT. And I would love for us to be able to have this kind of technology applied in that field where we can say, before I walk into my clip case, because of using simulation, I'm going to need two clips in this case, and they're going to be two NTWs in the middle will probably give me the best result. So I'd love to see more of that for this kind of technology.
Yeah. All right. Thank you very much for that. So let's move on to the final presentation of the first session. And I will be talking about advanced structural heart planning with 3D simulation and printing. Rakesh, so it's a little bit difficult to present and do my presentation without slides. So we're working on the slides. But what I'm going to talk about is a different way of simulation and printing even. So what we want to do is we want to simulate the intervention. And there are two ways of simulating. You can simulate it either with your computer or you can simulate it with a printed version of the heart. And this is what I want to talk about. So there are several planning software out there, and Lars already presented what FEOPS technology can do, and FEOPS already takes into consideration characteristics of the device and of tissue. With what I'm going to discuss, we take it from a different angle. And so, can we get the slides on? Yeah. These are my slides. But anyway, what I'm going to do is try to present them without... Do we have them? So anyway, we know that there are restrictions on a 2D screen to interpret complex anatomies. That is where the 3D simulation and also 3D printing comes into play, because you will get a better overview and you can even look for the best fitting devices for a particular anatomy, and it will enhance your planning. So you can proceed then with a more individualized planning methodology. And the goal of printing then at the end of the day determines also the printing technique and the kind of material that you want to use to make the prints. So let's move forward with the next slide. And this basically summarizes the technology. It is an automated way of evaluating a CT scan. And what you get is enhanced 3D visualization for a challenging anatomy. The illustration here below demonstrates what you can do in the mitral space. And then you can start to simulate in intervention, but you can also print the model, and then you would have the printed version of the heart in your hand, and you can do an implant in that printed model. So that can be quite interesting too. So the next slide, if the next slide can come, shows you an illustration of how that works. So this is a simulation, a computer simulation of an implantation. If we can run the video, then you can see that you can manipulate the implantation depth of the device in the mitral space. And by doing so, you can then assess what the neo-LVOT will be. And you can then evaluate a smaller valve with a larger valve, and you can evaluate a high implant versus a low implant. And that will have consequences in terms of the neo-LVOT. And you can immediately then interpret this neo-LVOT. So you can see here, if you have a smaller valve, the neo-LVOT will be larger than the larger valve. What is important is that you have to make the analysis, and it's a static analysis at this point in time, in the right moment in the cardiac cycle. And this is illustrated by a study from my fellow Joris Ooms that was recently published, where we do an analysis, we do a simulation and determine the neo-LVOT with with devices implanted at a particular depth, and we do the assessment at different time points in the cardiac cycle. And this is important. So if you look at the upper panel, there you see that in the early systolic phase, it turns out that the neo-LVOT in yellow, and then you go and see that the neo-LVOT is larger than at the end systolic phase. So if I scroll, so you have in the neo-LVOT assessment in early systole is much larger than a neo-LVOT at end of systole. And in the beginning, we were all measuring at the end of systole, but basically we were turning down a lot of patients based on this neo-LVOT that became too small at the end of systole. But of course, most flow happens in the LVOT during early systole, and this is why I think the projection or the acceptance rate of patients may get higher. This is what is happening now. We can take it to a next level and also use virtual reality to do these advanced analyses. And it becomes very funky where you wear your virtual reality glasses and then really have the heart in space, and you can turn it the way you want to turn it, and you can look at it from different angles. This becomes a very spectacular way of planning, and it's already reality. If you want to move then to 3D printing, this is one of the examples. So we have a printed model of the heart, and we were uncertain about the size of the valve that we wanted to implant. So what we did was we implanted the valve in our dry model, in our printed model. And then we were able to look at the result again from different angles, and we could appreciate the neo-LVOT just by looking into the heart from the left atrium, but also from the left ventricle. And by doing so, we were quite reassured that this patient could be treated with, in this case, a SAPIEN 326 millimeter in a calcified valve, mitral valve, and that patient ended up having a good result. So this is, I think, what we are doing these days. You can ask yourself, okay, but what does this 3D planning mean? What does it mean for my practice? Can I do it myself? Do I need to outsource it? Well, some of the centers have it in-house, this kind of software, and quite some academic centers are using this on a regular basis, also in my center, but you can also outsource it. And if you outsource it, you send these images to the company, in this case Materialize, and they will then do the analysis for you, and you get back an interactive report. Using that interactive report, you can then again have this 3D computer simulation and really appreciate how the valve will sit, what kind of effect the implant depth will have, and how the neo-LVOT will change in function of the device size and the implantation depth. So I think this is really a reality. You can already do that in your practice. You can either contact the company or you can have the software in-house. So to conclude, I think it's fair to say that advanced CT-derived 3D simulation, with or without printing, is now a key for risk stratification and procedural planning of complex structural heart interventions. Lars illustrated FEOPS technology. I was illustrating the Materialize technology. This really is not a technology of tomorrow, it is today. So you can really get prepared in a proper way and take the uncertainty out of the equation. And computer and printed simulations are complementary. So you can do a computer simulation, and when there is still ongoing uncertainty, you can then complement it with a printed version of what you have been simulating on the computer, and incorporation of multiple cardiac phases, but also tissue and device properties and hemodynamics may further optimize 3D modeling. With that, we can continue with the final leg of panel discussions. All right, Azim, first for you, do you often use this advanced technology, if you will? Do you use this materialized technology to plan, for instance, your TMVR cases?
We occasionally use it, Nicholas, not in all cases, but I think when we have those sort of borderline cases where we're not sure, will the valve fit? Do we have a high risk of LV outflow tract obstruction? I think it can be very useful there. The other place it's been very useful, and both me and Kendra and you know, we're involved with AccuCinch, which is this ventricular restoration therapy, and there it's been very useful to really understand the right guiding catheter that's going to sit in across the aortic valve, and to plan really the procedure. So, I mean, I think it can be incredibly useful, but like you mentioned, you know, for it to be useful, you also need to take into account tissue characteristics and so on. And so it's not just about having the heart, it's about having the valve, having the leaflets, and then having the right tissue characteristics for it to be useful. There are a number of technologies, early technologies, where I think it's almost essential to plan the procedures and to be sure the device is going to work. We've done some first-in-mans and tricuspid with new valves where in the preparation for the procedure, we've done the valve implantation over and over again under fluoroscopy on the plastic model, and it's really helped us to understand what to do at during the procedure.
Yeah, but I think you agree that there is still a mental exercise here, right? Because you have these static reconstructions, but you still have to take into consideration, as you mentioned, the device-host interactions, but also the hemodynamics, right? Because sometimes the patients were overfilled when they were getting these tests, and then on procedure day, they were relatively volume depleted.
Right. That's been, you know, for tricuspid especially, that has been one of the biggest challenges. We've had patients who, for tricuspid valve replacement, they were initially turned down. We then diuresed them, did the CAT scan again, and suddenly we could get them into a clinical study. But then you have to be so careful that on the day of the procedure, they're in the same state as they were on the day of the CAT scan, because so much can change. And so that's the challenge, especially on the right side. I think with using, you know, these models is, like you say, the volume and dimensions change incredibly.
Yeah. Kendra, are you using these more advanced CT techniques, or do you stick to regular everyday CT?
We are using the more advanced techniques for all of our mitrals and certainly tricuspids. And as Azim was mentioning, even going to 3D models for some of them, and certainly for all of the ventricular remodeling devices.
Yeah. What are the limitations of these printed models, in your opinion?
Well, it goes without saying that you already discussed kind of the heart is at whatever phase it is when you assess the patient. So especially on the right side, is the patient volume overloaded when they had their CT? And so that on the table, their heart's going to be drastically different, or vice versa. And so the limitations are the static phase of whatever that patient was in terms of how optimized they are at that moment when they got the CT scan. And so that's always going to be a limitation. It is going to give you a very good sense of overall structure, and certainly if you're talking about mitral and there's calcification, you're going to understand that. But I think that you have to consider these as a guide. It's not truly a simulation yet.
David, what is your take on this? Is this a nice to have, or is this must have technology?
Yeah, so just thinking about it as we were talking there, I mean, you can see why it's become so crucial in TAVI, because that really is a pretty static anatomy. relatively speaking. Whereas, as Azim says, particularly on the right side of the heart, things are so dynamic. The degree of tricuspid regurgitation will vary enormously with things like dialysis or degree of diuresis. And that's probably also true for the left atrial appendage, and maybe why I'm not that interested in doing a CT pre-planning, because I think, well, you know, the left atrial appendage itself will change dimensions quite considerably with volume loading. So I think, yes, it's obviously nice to have. It's obviously very good for research purposes. We help learn a great deal about these procedures by doing these things. But, you know, stuff like the materialize possibilities have been around for some years without ever really catching on into a mass market. So I don't know whether it's necessarily going to prove ever to be more than nice to have.
Well, personally, I would never embark in a TMVR case without my materialized analysis at this point in time, because really it gives you so much enhanced insights and takes a lot of uncertainty out of the equation, as I mentioned. But I do take your comments that we've become quite experienced and efficient also without advanced technology. But I think at this point in time, you know, the stakes are getting higher. We're treating more and more younger patients. Then I think the better you're planned, the better you're trained, the better the results will be. But I think we are coming at the end of the first session, so why don't we bring up the poll results? We had that poll question: do you think TMVR will become an alternative to surgery in patients at low operative surgical risk? And 85% of the audience thinks it will. Woof, that is a little bit unexpected. I was more expecting like a 50-50 split. Kendra, what is your opinion on this as a surgeon?
Well, I think that that's going to be the natural progression. I think that what we've seen in TAVR certainly, and sure we need the 10-year data, is that there is equipoise, especially in certain patient populations. I expect this over time to be the case for TMVR as well. Right now, we do not have devices that are ready for prime time, but as these devices are refined, as the size of the instrumentation becomes smaller and more user-friendly, I do believe that you will see in the mitral space the same thing that you've seen in the aortic.
I think that is important what you just mentioned. The devices as they are today are not ready for prime time and to compete with surgery in younger risk patients, right? There is a segment of our patient population that really is at almost prohibitive operative risk. And obviously in those patients, what we have today can be very valuable. Would you agree with that, Azim?
Yeah, I think, you know, mitral, it's such a heterogeneous and diverse group of anatomies and patients. So, you know, we have to be really specific about what we say. So when it comes to, you know, degenerative mitral regurgitation, I'm not sure we can do better than what Kendra can do right now, right? And not for a long time. I mean, Kendra surgically can repair a valve and give that patient a long-term durable outcome, which I think is better than replacement. But if we start talking about FMR, then maybe yes. I think there, you know, more and more we'll see replacement becoming a predominant therapy. But also there, I don't know about you guys, but there's still a large groups of patients with mitral valve disease that I don't have a solution to in my practice. So I see at least 1 or 2 cases a week that I turn down, that surgeons have turned down, I turn down. And the reason being, they're those patients who have, you know, in their late 70s, 80s, they have calcium on their annulus, but it's not enough to anchor a valve. They have calcium on their leaflets, and the annulus is small, so you can't do mitral clip on them without giving them a gradient. You can't put a valve in them, the current valves we have, because they have some mitral stenosis. And we see a lot of those patients that I think we still don't have a solution for. Add to those, and we don't talk about them enough, all the rheumatic patients as well, or patients who had rheumatic disease when they were younger, and now we're seeing them when they're older. You know, rheumatic fever hasn't disappeared. We just don't talk about it because it's not a problem we see in most countries, first world countries, except where I work in New York, in the Bronx, we see tons of rheumatic disease, whether it's from local or from patients who come from elsewhere in the world. So I still think there's a large group of patients out there that we still don't have solutions for. It's great that replacement is going to play a bigger part, but we shouldn't forget there are a lot of patients we still need to find solutions for.
That wraps up the first hour of TIO 2022. I think it was very exciting to see the TMVR technology that is already present and in development. I think we also illustrated quite well advanced CT planning tools. And you already noticed that Lars left the panel because he's now going to open up the first live case for TIO 2022. So we moved to Copenhagen to Professor Lars Sundergaard and Professor Ole de Bakker for an LAA closure case. And then also simultaneously, but basically 30 minutes later, we will go to Leipzig for the first time and discuss a TMVR case. So we'll see you after the jingle.